Type 2 diabetes is the most common type of diabetes. It's caused by not enough insulin and/or the tissues are resistant to insulin. So insulin is being formed in this type. Either not enough of it is being made or the tissues won't use it. Comorbid conditions are conditions that go along with diabetes commonly. First is obesity. The next is coronary artery disease, high cholesterol and/or lipids, hypertension, and blood clots. When we put all these comorbidities together, we call it a metabolic syndrome or insulin resistance syndrome. So if somebody has all these or most of these comorbidity conditions, that's when we call it the metabolic syndrome or an insulin resistance syndrome. Long-term complications for both types of diabetes: we've got a buildup of atherosclerotic plaque in the coronary, cerebral, and peripheral vessels. That means the blood can't get through quite as well. So we have decreased blood flow to some areas of the body. We also have, with diabetes, capillary damage. And we typically see that as retinopathy, that's damage that happens in the eyes, neuropathy, damage within the nervous system someplace. Quite often we see it peripherally, and nephropathy, or kidney damage. Gestational diabetes develops in pregnancy, and if it's left untreated, can end up having a fetus with birth defects or a fetus that dies. This type of diabetes usually goes away after delivery. However, a woman who has gestational diabetes has an increased chance of developing type 2 diabetes later in life. Okay, fasting blood glucose levels. That means they haven't eaten anything. This is first thing in the morning blood sugar draw before anybody gives them something to eat or drink. In someone who does not have diabetes, a fasting level should be 70 to 100 milligrams per deciliter. If their fasting level is between 110 and 126, we call that pre-diabetes. We need to be watching them and helping them make some lifestyle changes, maybe some exercise, and watch what they're eating. And regular old diabetes, if the fasting level is greater than 126, that is consistent with somebody having either type 1 or type 2 diabetes. The other blood level that we follow is the hemoglobin A1C, and that tells us how have they been doing with their blood glucose control over the last month or so. We want it to be less than 7%. That means less than 7% of the hemoglobins have glucose connected with them. Treatment for diabetes. Well, if they have type 1 diabetes, remember that means they're not making insulin, so we've got to give it to them. Type 2 diabetes, we're going to try and treat with diet and exercise. If that doesn't work, we're going to add some oral medications, and if that doesn't work, we're going to go ahead and start giving insulin. So insulin is the last step in the treatment for type 2 diabetes. Insulin, when we give it to them with a shot, it works just like regular old insulin made by the body. It helps to restore the body's ability to metabolize carbohydrates, fats, and proteins. And it helps the body to store glucose in the liver. And it also helps to convert glycogen into fat stores for further use. The goal of treatment, of all these treatments, is to help someone maintain a tight glycemic control and thereby reduce or avoid long-term complications. Okay, so when we're giving someone medication to treat their diabetes, to lower their blood sugar, we are risking the occurrence of hypoglycemia. That means blood sugar that's too low. Early signs of hypoglycemia include confusion and irritability, tremors, sweating, pale and clammy skin, hunger, headaches, and a blurred vision. Now, if we don't catch it, if the client doesn't catch it or we don't catch it, we can end up with hypothermia and seizures, and eventually this can lead to coma and death if we don't get them the appropriate treatment. Hypoglycemia is defined as blood sugar that's less than 50 milligrams per deciliter, and if it's a fairly mild case, it can be treated by having them eat or drink protein and decrease the amount of carbohydrates they've been taking in to prevent rebound hypoglycemia. If we just give them something like soda or orange juice, sure, it shoots their blood sugar up right away, but doesn't stay up. And it drops right back down to being hypoglycemic again. So milk is a better choice for these milder cases. Now, assuming the patient is able to eat, we ask ourselves, is a meal or snack due? If so, get them to eat the meal or the snack. If it's not due, consider milk, or if you have to, juice, glucose tablets, lifesavers, that kind of thing, crackers, half a sandwich, but we need to remember not to over-treat. If we give them all the things on that list, their blood sugar is going to be out the roof. So we treat it very sparingly, and we monitor blood sugar. If they cannot eat, we're going to give them glucagon, or have the family member give them glucagon, which is a shot, which brings up blood sugar. And again, we're monitoring blood glucose, but we have to think about this. Yes, we've given them the glucagon, their blood sugar has shot right up. It's going to drop right back down. We're going to have rebound hypoglycemia if we don't give them some other form of complex carbohydrate or protein. Before giving any drugs that alter blood glucose levels, you've got to check their blood sugar first. Assess their ability to consume food and make sure it's going to stay in them. If they're having nausea and vomiting, consuming food's not going to do any good because it's going to come right back up. Remember that stress, infection, illness, pregnancy, lactation all change the metabolic patterns of the individual and will change their insulin needs.